Welcome everyone to this evidence-based mental health Google Hangout today. Thank you for joining us. We have a terrific panel of discussants. This week I'm Michael Ostacher, professor of psychiatry at Stanford University School of Medicine, and I'm the digital content editor for evidence-based mental health. Today we'll be discussing a commentary. School of Medicine, and I'm the digital content editor for evidence-based mental health. Today we'll be discussing a commentary. School of Medicine, and I'm the digital content editor for evidence-based mental health. Today we'll be discussing. I apologize for the delay. Today we'll be discussing a terrific commentary by Christoph Correll and his colleague, Marco Solmi, on adjunctive minocycline and schizophrenia, what one well-controlled study can tell us and what it can't, which was a commentary on a paper about the BeneMin trial published in Lancet. We're joined today by Christoph Correll, who's professor of psychiatry and molecular medicine at Hofstra Northwell School of Medicine in New York, investigator at the Center for Psychiatric Neuroscience at the Feinstein Institute for Medical Research, and the medical director for Recognition and Prevention Program at the Zucker Hillside Hospital in their Department of Psychiatry. We're also joined by several terrific colleagues. First, I'd like to introduce Andy Nierenberg. He's the Thomas P. Hackett, MD, Endowed Chair in Psychiatry at Massachusetts General Hospital. Andy is the reason I have a career in investigation in psychiatry. We go back nearly a couple decades now, where Andy helped me get my feet off the ground with my research career. He's also the director of the Dauten Family Center for Bipolar Treatment Innovation at Massachusetts General and professor of psychiatry at Harvard Medical School. We're joined also with an old friend, Dan Iosifescu, who's director of clinical research at the Nathan Klein Institute for Psychiatric Research and a professor of psychiatry at NYU School of Medicine. They've each done their own work in inflammation in psychiatry and will be terrific to add to this discussion. We may be joined later by Roger McIntyre, who's a professor of psychiatry and pharmacology at University of Toronto. If Roger joins, we'll loop him into the conversation. To start, I want to say thank you to everyone again for joining. If you'd like to comment live, if you're watching this live, please send comments through the Twitter hashtag EBMH chat, that is hashtag EBMH chat, and we'll try to answer your questions live and bring them to the panel as you send them to us. To start the conversation, Professor Correll will be discussing his commentary on the specific paper, and then we'll broaden the discussion from there. Christoph, would you like to begin?
Sure. Well, first of all, thanks for inviting me to this nice hangout, and hanging out with you guys is terrific, even though we're not in the same place. And so we'll discuss the commentary first, but that will only be the springboard to actually address what inflammation may or may not tell us about mental illness. So this is the study that was published, the BeneMin study was published by Bill Deacon and also Tom Barnes and the BeneMin study team. It tried to test whether the antibiotic minocycline that has neuroprotective and anti-inflammatory properties could also prevent or reverse progressive neuropathic changes that are implicated in recent onset schizophrenia. So this was a randomized, double-blind, placebo-controlled trial, relatively large, actually the largest study so far with minocycline and schizophrenia, recruited 207 patients, 104 randomized to minocycline, 103 to placebo, and it was actually a 12-month study, so it's also a long-term study. Furthermore, I think a big strength is that they looked at biomarkers in order to seize their target engagement, and can we see that something beyond symptoms in the brain and in the body of the patients changes. And the biomarker outcomes included medial prefrontal gray matter volume, dorsolateral prefrontal cortex activation during a working memory task, and also plasma concentrations of interleukin-6, which is obviously one of the prime inflammatory markers. Now, this study has several strengths. It's relatively large, sufficiently long duration, tested a potential biological target engagement, and had attempts to guard against biases such as radar imprecision and non-adherence. The dose was 300 milligrams per day, which was actually higher than in previous trials. Surprisingly, the results were totally negative, and they contrast with data from two meta-analyses. One actually done by Marco Solmi and myself, where there were 6 RCTs in 413 patients, and there was a significant benefit of minocycline in patients who were more acutely exacerbated and chronically ill, both for positive symptoms, negative symptoms, and global impression of the illness. Actually, the negative symptom effect size was 0.76, which was pretty large. Basically, that was the one. The second meta-analysis added 2 RCTs from China that were published in Chinese, had 548 patients, and again showed benefits in the total symptoms and the negative symptoms in a similar, like 0.5, 0.6 effect size range. So what are the reasons then that this study was negative? And I think there are several that we discussed. They were also partly or largely acknowledged by the investigators. First, and I think very important for our discussion, is that although the target of the medication and the biomarker was inflammation, the values, the mean values of interleukin-6 were only 0.84 in the placebo and 0.69 picograms per milliliter in the minocycline group. And that is far below the upper physiological value even of interleukin-6, which is 5 picogram per milliliter. And I think this highlights a problem in many of the studies where the treatments that we investigate have a biological target, that patients are not enrolled that are enriched for that biological target. Usually these are used as biomarkers post hoc to see, oh, if there's variation and there is a higher value, are these patients responding better or worse? But then you totally underpower your study. So the IL-6 was too low. They also didn't see anything in the brain-based assessment of microglia activation. And maybe this patient population was basically just not sick enough in order to show any of these. Or, as Bleuler has said, we need to talk about schizophrenia in the plural. It is not the inflammatory subtype. And I think one other important aspect of the study needs to be highlighted, and that is it looked at prevention rather than intervention. And our targets that we use biologically may be different when we want to prevent worsening of negative symptoms than treating severe negative symptoms. So the studies in the other meta-analyses had actually an enrichment for severity of positive and negative symptoms. Here, the negative symptoms were relatively benign and low in this first episode sample that had responded to treatment, which is a subgroup. And then expecting that minocycline could prevent worsening, even though both placebo and the minocycline group improved the negative symptoms. So even the placebo group did not worsen, then you can't prevent anything. So maybe this tells us that there were too many questions that were asked in this study, and the sample didn't necessarily match the biological target because we believe inflammation might be related to poor outcome, non-response, or to severity of illness.
You know, Christoph, that's really interesting for so many reasons. And I think that many of our studies that look at prevention of any event or any outcome are really many times challenging when the events don't happen, right? Because in effect, we power these studies based on some assumption of subsequent events, and you have no control over it. So when the events don't happen either in the placebo group or the active group, it looks like a negative study, but it's not quite negative. It's just not informative.
Yeah.
But there's an additional piece of this that Christoph outlined, but I think it's worth underlining it. As far as we're talking about neuroinflammation and its role in many of the psychiatric disorders, and there's a lot of data to support that this is something we need to pay attention to, but there's also data to suggest that the people where this plays a major role are a subset of the larger groups of individuals that carry those diagnoses, and that if we look at interventions with specificity on neuroinflammation, really starting with a generic sample is very much at risk of washing out any potential results. And that's really something that we need to spend a lot of attention to, even before we start these studies and also when we analyze them.
Absolutely, I totally agree. So I think prevention studies are difficult if you haven't enriched for the actual event. And if patients on placebo improve, you have a big problem. It's basically non-informative rather than negative. And B, you need to enrich for the target that you're actually addressing or trying to address with your treatment. And I think that goes back to biomarkers of subgroups of the illness. And we're not good enough in psychiatry yet in that area.
Yeah, and in fact, I don't know of a single study that has actually been successful that's stratified by a biomarker that was supposedly the target of the treatment that actually has worked out. I mean, unless you guys know something else, I've not seen that yet.
It's a problem. Let's welcome Roger to the call. Roger.
Welcome, Roger.
Hi, Roger.
To the call. Yeah, that's okay.
And just to pick up on that comment about subpopulations, I've become increasingly skeptical as a strategy, but certainly the focus being on inflammation here today, that really subpopulations is going to be enough of a homogenization process, given the very poor Cohen-Kappa correlational coefficients we have in psychiatry. I think we really need to, in fact, be thoughtful about this. And the notion of looking for a biomarker for a phenotype, for example, in major depression with 0.28 inter-rater agreement on kappa, bipolar disorder, 0.4 to 0.56, bipolar 2, bipolar 1 respectively, is the kappa correlation. By its very definition, just a bit of Socratic reasoning, if you don't agree on the phenotype, it is very difficult, in fact, to have a biomarker. So I think, in fact, that for me, increasingly as a strategy, and it's why, in part, I've been interested in the metabolic and inflammatory interface, more specifically cognition, with measurement of motivation, reward, circadian rhythm, because I think it's a much more, it's dimensional, but it's also much more of a reliable, replicable phenotype. And to Andy's point, I'm also not aware, the way, Andy, you put it, in terms of stratification. We've recently been able to show that bipolar patients who have
I think we might have lost Roger.
I think we lost Roger froze.
No,
We'll hear his result on the bipolar patients later, I guess.
Yeah. Well, Roger, let me bring this to Christoph. So Roger's talking about something that I think is really important, which is that our phenotypes are so broad that expecting a biomarker to be able to identify them is problematic given the phenotypes themselves. But if you're just looking at whether or not inflammation within whatever broad phenotype you're looking at is something that you need to stratify by, or at least enrich for your sample, is something I think that's worth discussing, because you would then think, especially from what you had said, that if people don't have high inflammation, they're not likely to respond to a treatment that impacts inflammation. Is that correct?
Yes, and I think the problem is also, we say inflammation, but even inflammation is a heterogeneous concept. You can look at high sensitivity CRP, which was somewhat enhanced or higher than normal in the BeneMin population, but people with mental illness have abdominal obesity, smoke, and all of these factors also feed into certain inflammatory markers. So I wonder whether there are also other markers that are closer to the brain or less lifestyle influenced, and we need to disentangle that inflammatory black box also. Is it TNF alpha we're targeting, IL-2, IL-6? Is it high sensitivity CRP? What is your read of the literature there?
Yeah, and if I could comment on that, I think we're really oversimplifying the inflammation story, because what we really have is an inflammasome. And the inflammasome is made up not only of all of the pro-inflammatory cytokines, but the anti-inflammatory cytokines. And it's a very complex network and an interplay of many of these factors. So when we choose 1, 2, or 3, I think we're not quite even looking at inflammation in a comprehensive way.
I think that's an important point, but also I wonder whether inflammation is just an intermediary factor, and we need to look at what inflammation does or doesn't do in certain patients. How is it intersecting with, for example, oxidative stress? What are some endpoints or common resulting pathways we need to look at? Because if you look at meta-analyses of inflammation in psychiatry, everything seems to be associated with inflammation, whether it's mania, depression, psychosis, OCD, PTSD, even suicidality. So we then did a meta-analysis of eating disorders, anorexia, because we felt, okay, they don't really smoke usually, and they don't have obesity, but even they, being 15 centimeters less in terms of like abdominal waist circumference, had also inflammatory markers. So it seems to be a very non-specific component of mental illness that maybe brings out some genetic or other factors that then have a pathway into mental illness and severity. And we're not there. I think we're at the moment doctoring at the surface.
So let me ask you
to that
guys,
point, Andy.
let me ask you guys a fundamental question, because what Christoph was saying is that if you look for an inflammatory problem, you can find it everywhere. And the biggest question is it causal? Is it an epiphenomenon? Where does it come from? Is it secondary to whatever disorder is going on? And as you may know, Michael Burke has a hypothesis that it comes from a mitochondrial dysfunction, which then leads to cellular damage, and the cellular damage is what provokes the inflammatory response. I'm really interested to know your.
The way I'd approach that, Andy, I sort of see this as all the above: cause, consequence, and comorbid. And in many cases, it could be confounded by something else, like a habitual inactivity, smoking of cigarettes, and so on. So it's cause, consequence, often comorbid, and it is in fact sometimes confounded, and that makes it complicated. But I think, in fact, we can say with some degree of certainty, if one looks at the concatenation of preclinical and clinical data, particularly from a longitudinal perspective, that there is a subgroup. There is a subgroup that's not a large subgroup, but not an insignificant subgroup, where the word association can be supplanted with causation. But there seems to be some causative aspect. Now, I liked your point, Andy, about, it's unlikely a single marker. It's hard to put this together, and I agree. I think it's intellectually less interesting to look at CRP. And there seems to be, I think, a somewhat anachronistic emphasis on these non-specific markers. It seems to be a composite or a biosignature, which is not very hard to create with machine learning, etc. Probably much more empirical, much more comprehensive and coherent, and not very difficult to do, actually. So yes, it's complicated. I doubt it's a single marker. I suspect it. You mentioned the inflammasome. Absolutely, it's the inflammasome. This brings together the pathogen as well as the damage-associated molecular patterns. It also involves other aspects of the milieu. Now, for me, mitochondrial dysregulation is a very interesting hypothesis to proffer, and I see it as in key this whole view that inflammation, as we're talking about it, is cause, consequence, comorbidity, and confounding. And so mitochondria could fit into one of those.
Yeah, if I may just take another point here. So I think, Andy, you're right that these abnormalities can be detected in all these psychiatric conditions. But what's really important here is that not everybody with these diagnoses has them. So there's a large subgroup, actually the majority of patients in most of these categories that actually do not meet our criteria for neuroinflammation. The other point that Christoph was making earlier is whether we are still good enough by just looking at peripheric markers of inflammation, which are more sophisticated and easier for us to access and measure. But at the end of the day, does that really reflect what we are looking for, which is inflammation at the level of the brain? I want to mention here an article that we published last year. It was a much smaller sample using minocycline as an add-on treatment in people with bipolar depression who had not responded to more traditional mood stabilizers. And while the study it was an open study, did not have a placebo, what we did with that was quite interesting was to use magnetic resonance spectroscopy to measure certain metabolites that are really very important for neuroinflammation and for oxidative stress. And the most interesting here is a neurochemical called glutathione, which is essentially the most important antioxidant in the brain. And while our sample really split 50-50, and we had about 10 patients who responded to the adding of minocycline and 10 who didn't, really we found very interesting correlations between both the baseline level of glutathione, so before treatment, the future responders and the future non-responders were really very different. And then also the people who responded to treatment had completely different patterns of change in the levels of the antioxidant glutathione compared to the people who did not respond. So while this was still a small study, I think to me this is somewhat more close to what we need to do in terms of both trying to tease apart the role of inflammation and of oxidative stress in these conditions.
Explain a bit more what you mean by what we need to do more of.
I'm sorry?
Yeah. Say again what you think. Explain again what you think we need to do more of going forward in order to make sure the studies provide us with the data that we need.
Well, I think what Dan was saying was like trying to map the story from the peripheral markers onto the brain, and also integrating different systems that have similar or opposing effects. As Andy was saying, it's inflammation and anti-inflammation markers, but it's also inflammation and oxidative stress, which might be very closely correlated. So this way would be great to also have peripheral as well as central markers and multiple players, if I paraphrase you correctly, Dan.
Yes, absolutely.
Yeah, what I like about Dan, your study, is that you've attempted to at least provide the first chapter in our comprehensive book of trying to understand how, in this case, you use minocycline not just as a treatment, but I would say minocycline also represents a probe. And minocycline, which you're hinting at, has this effect on oxidative homeostasis. It also has effects directly on microglia, shifting it from a pro-inflammatory phenotype to a less inflammatory phenotype. This is often referred to as M2 and M1 shifting. And we also know that minocycline directly affects peripheral inflammation as well as the gut biome, the gut biota. So I think what I like about your study is that your study is in fact attempting to inform mechanistic pathway around any salutary effects we have. And for me, that's been more interesting. We use minocycline in mood patients, but I think what's particularly interesting is trying to suss out this mechanistic story And all of these mechanisms that I mentioned are not mutually exclusive. And so that's what I think is really the value out of your study, Dan.
But Dan, would you follow up now with a study to say, I only take the 50% of responders that have certain glutathione levels, and now do the next study in them, placebo-controlled? Or what do you learn of this probe? I think we need to use more probes in psychiatry, because challenging the system and seeing what happens, even if it's like after 1 week, as you said, there is a different change pattern. This is really crucial. Otherwise, we just look at static elements, and the brain is not static.
Yes, I agree, and I would definitely try to use a combination of peripheric and brain-based measures of inflammation and oxidative stress as a way to define the subgroup where these interventions would be most informative. I absolutely agree with that, and I also agree with the link that Andy mentioned earlier between inflammation, oxidative stress, and mitochondrial dysfunction. Those are all three of them, relatively fuzzy concepts, but it gets us closer to perhaps a mechanism for how these could happen, and also tries to answer the question that was discussed earlier. Is this an original cause, or just an additional factor that plays a role here? And it may well be that it's an additional factor, but it has a very important role in that subgroup where this is very prevalent.
So are we at a stage in psychiatry where we would recommend to psychiatrists to measure inflammation, certain markers, TNF-alpha, IL-6, IL-2, and then say, okay, for you, I give you non-steroidal anti-inflammatory drugs or minocycline. Are we there yet? Or what do we have to do until we can get there?
Yeah, I don't think
we're...
Sorry.
Let Andy.
Go ahead, Andy.
Yeah,
Go ahead.
I don't think we're even close to that. So we're in, I think, a stage now where we need to figure out what are the most relevant brain-based biomarkers that might be able to subtype people biologically, and then we could perhaps do the studies to see if this has any traction enough so that there's a difference to recommend things to the clinicians. But I don't think we're even close to that now.
So you're saying that in a clinical
Sorry, can I follow up with one question? In this study, if we use inflammation to parse populations, would that be within diagnoses, or would we just say transdiagnostic? Who cares? Because if there's this inflammatory subtype of severe mental illness, we can then later on subdivide, but would that give us more power? And would you just say, let's bring down however we measure depression, mania, or psychosis? Or is that too mixed and heterogeneous again?
Well, my own view to that, Christoph, is I don't think it's more mixed than the current status quo. I think if you took a sample of bipolar persons with bipolar disorder, that's quintessentially heterogeneous. There's no way we're going to get more heterogeneous. And so I think, in part, you're getting at more of an RDoc question around dimensionalizing and domain-based and being more transdiagnostic. So my bias is more towards that, because inflammation, we're talking about inflammation being potentially causatively related to illness and potentially a therapeutic target. But I think just to sort of break that down, inflammation is not significantly linked to some aspects of psychopathology, but it is significantly linked to other aspects like reward deficits, motivational deficits, cognitive deficits, and sleep alteration, just to name a few. And so I think clearly it's transdiagnostic, and I think it's not only provides an opportunity for power, but I think it's definitely accurate. And so as we think about these subpopulations, we think about these ideally dimensionally and domain-based. The other area, I don't know if this came up already, is the issue of people being exposed to trauma. And this is a population we know is common across the entire spectrum of psychiatry. And we now know that this group is particularly activated when it comes to altered immune inflammatory systems, and they don't respond to conventional treatment. So subgrouping needs to be biomarker informed, but I think often subgrouping, I think the opportunity with inflammation is not just a certain dimension domain, but also a subgroup that's been exposed to trauma. And that group is particularly, I think, exhibiting altered inflammasome activity and may in fact be preferentially responsive to some of these anti-inflammatory interventions.
Yeah, I think to go back to Christoph's point is, the question is, should it be the case that we routinely measure inflammatory markers in people? And I think the answer is probably in research, right? Is that what people are doing?
I think so. I think in research, but let's not forget that people who have bipolar and schizophrenia have staggering rates of cardiometabolic disorders. And so if we were to see them as people who had a cardiovascular risk, then there'd be a role for checking, for example, CRP. But simply from the point of view above the neck, in terms of the brain, I agree. I don't think we're there yet clinically to make that recommendation. I think it's more the ecosystem of research at this time.
Well, the other point is, if we do start recommending people to check inflammatory markers, we should have some very clear ideas of what we tell them to do once they find them. And we need to really underlie that all the recommendations that we could give at this point, while making sense on a commonsensical basis, are not really fully supported by data. And that whereas someone who has a lot of inflammation, either because of tests or because of their comorbid medical illnesses, may be a good candidate for either minocycline or omega-3 fatty acids or what have you, there's really not enough data to say, yes, you should be doing that. And as far as typical anti-inflammatory medications like NSAIDs, there's actually a lot of data that they don't really work for these types of things.
So, Dan, I'm going to make one counter argument, and the counter argument actually is a little counterintuitive, because I think we can learn from big data in ways that are creative. So, my colleague Ola Kola-Forsberg and I and some other people, among Soren Ostergaard and Ole Andersen, looked at the Danish database and asked a very simple question. For those people who had a diagnosis of depression and who were taking an SSRI, if they also took a statin, was their outcome better? And so we ended up looking at 1 million people who took SSRIs, about a third were taking statins. We did all the adjustments we had to do because of the age difference. And it turned out that people who were taking statins had better outcomes. And there's an anti-inflammatory component of that. So I think if we look carefully and creatively in there, and as Roger said earlier, you can also use machine learning and other ways of looking at those data, maybe we can get some clues that would inform our clinical trials. And then, eventually we might be able to have certain combinations of things that do target inflammation that might be helpful to patients.
What were the specific outcomes that you saw that were better in that analysis of data?
So we looked at the hard outcomes of hospitalization and ER visits.
Now the question, the confounder could be, I don't know whether you were able to control for that those patients who took statins were just more compliant with everything because they also went more to doctors and had more monitoring and all the rest of it.
Yeah, we did as best as we could do. We did a propensity analysis that it survived.
Mm-hmm. How about things like cardiovascular risk factors, which we've shown in the past that these were really markers of worse outcome in mood disorders, and therefore by taking statins, you may be lowering that risk without necessarily having a direct impact on inflammation.
Right, and that's certainly a possibility. What I'm really suggesting is that we can learn something from some of these natural type of experiments with all the caveats of non-randomization and potential biases.
Right,
but we may be able to get some clues.
Yeah, but this doesn't counter that we are not yet at the position to say measure it because and then treat with statins, because we first need to learn something. Because if you measure and you don't have an evidence-based treatment, then we have a problem. So we definitely need to learn something more about it. I fully agree. Could it be metformin also? I mean, some of these data sets might inform the next large simple trial.
Yeah.
Well, and there's the Jupiter trial. Is that with the torvastatin or rosuvastatin?
That's right.
Rosuvastatin that looked at high CRP for people who were had normal lipids, and randomized them to get rosuvastatin, I believe, or a placebo, and they had much better all-cause mortality outcomes in the group that got the statin. I mean, it doesn't speak to mood disorders in any way, but it is important, I think, to know. And it's also that it may be that just because they took people who had high CRP levels and put them on statins and they lived longer, that it has nothing to do with the CRP level, that it might have just been that that statins prevent heart disease even in people who don't appear to be at risk, and the CRP levels were not the factor on which it was most relevant.
Did they measure the decrease in CRP? Did it go down also? And was that related to the longevity? Or did they only look at this at baseline? I don't know the study, but that would be interesting to look at. Okay.
But I think we need to maybe even take a pool amongst ourselves, because this is, every time I give a talk about our research on neuroinflammation and other people's results, I automatically get people in the room saying, okay, so should I do this to my patients, and what should I prescribe to them once I get these tests, and what value should I use to start prescribing? And those are very legitimate questions, but and how many of us, just because these interventions are relatively okay to prescribe, would feel comfortable recommending them at this point in time?
Well, that's a good point, Dan. I also think that, you know, when I'm asked that question, which is all, I think that there needs to be, in fact, recognition that, we've been using the word transdiagnostic as a conceptual framework vis-a-vis dimensions cut across categories. We think inflammation may be relevant across some of these dimensions, but also the modality of intervention. I tell clinicians that perhaps the most potent anti-inflammatory pill you can give your patients a good night of sleep, losing some weight, long-term exercise, in fact, mindfulness therapies. These are all convergent evidence, all anti-inflammatory and not too controversial, I think, from the point of view of safety and toxicity. So I think that not all roads lead to a pill. But the other part I want to emphasize is, for me clinically and as an academic in this area, what I find to be more proof of the principle that an anti-inflammatory is therapeutic is not from the conventional anti-inflammatories, NSAIDs, TZDs, thiazolidinediones, incretins, statins, and for me, the best proof of the principle comes from SSRIs. And so we know that interferon, pegylated interferons, the most depression-causing drug in medicine, with new onset cases, 30 to 50%. And you guys know that the prophylactic use of an SSRI cuts the incidence of interferon-induced depression in half. And this is standard in my program. We give, for example, hepatitis C patients or malignant melanoma patients who are not depressed, they're pre-treated with an SSRI. And so that has conceptual relevance. About a half a dozen studies have shown this now. And that's a very powerful proof of the concept that engaging the immune inflammatory system with an inflammatory drug called an SSRI, in fact, has beneficial, this preventative effect. Andy, you spoke to the population-based beneficial effect. This is the beneficial primary prevention effect in a clinical ecosystem, and a very powerful effect in relatively small numbers of patients. So for me, that's always been the hopeful message, that perhaps by getting that sweet zone of engaged, be able to, yes, treat, but also perhaps even prevent some of these new onset cases.
The other thing I would say that complements that is the really intriguing data that lithium decreases all-cause mortality in bipolar patients. And it also has an anti-inflammatory effect.
Yeah, what were you thinking about that, Andy?
Yeah, it sure does. And I remember, when lithium was first described as helping, we know it has anti-agents, that it works via immune modulation of viral viral replication in the brain. So an interesting concept. Don't know if that's entirely explanatory, but certainly touched on some areas that now we're just revisiting.
You know, I also have to say that the current at least research funding environment through NIMH is not really very friendly to looking at multiple pathways and to look at multiple ways that we might be able to help people. And Dan and I have had the experience with really getting grants rejected because they were both anti-inflammatory, antioxidant, and had effects on glutamate. So I think we have to perhaps expand the way we help our colleagues who review grants think about sometimes you need to have multiple targets to figure out what's happening.
Especially if they're interacting.
Yeah, and they're interacting. Right? It's none of the targets are in isolation.
Well, I mean, I think you speak to several issues that are in play in terms of funding from NIH. Is that you have to be novel in order to be interesting, but if you're novel, then people will not understand what you're trying to accomplish. but I think it's. But I think your point is really an interesting one, Andy, which is that they presume that you know what the target is doing before you've done your study to find out what the target is doing, and that sounds like you were proposing something that was more exploratory in terms of having multiple targets, and that they were not favorable to that.
Well, I think it's very hard to think about multiple targets, and it's easier to think that, well, you have one target, you're going to hit it and do something, but you have no idea what it's going to do, but at least you'll hit a target. Maybe you'll know you're hitting something, but it may be the wrong thing. You just have
Christoph, I like to see you laughing. What were you thinking?
No, well, yeah, I mean, it's the current environment is you need to show some target engagement. You don't even know whether that means anything. And there are things where you don't have target engagement, but you move the needle. So,
exactly.
Yeah, I think
exactly.
I mean, we're a little bit boxed in right now.
Right. So to go back to the Jupiter study, the rosuvastatin study in cardiovascular events, yeah, all-cause mortality was decreased by 20%. And yes, the people who had bigger drops in LDL-C and in CRP did the best, but it's still only. But it really only answers the question: do fewer people die, really? And it's only exploratory on the causality of that, right? So you do a study, you have a hypothesis, and I think it's important for us to recognize that the ultimate outcome is the one that's where we should be the most interested in. In psychiatry, it's difficult because we have lifelong disorders, and we're looking at necessarily short time frames for outcomes, and so our outcomes are always going to be a proxy for what we're really interested in. So we probably are interested in all-cause mortality in psychiatry. We just don't have the number. I mean, that's probably important. Or all-cause divorce, or all-cause unemployment, or something really, broad. But we don't have the sample size usually to look at those sorts of things. So we look at proxies for what we think are important. But nevertheless, we choose what the proxy is, and that should be what the outcome is, and then we can try to understand what the mechanism is underneath it. And I think the minocycline studies are an important example of that. Right? We have a hypothesis about how minocycline might be affecting inflammation. The question really is, do people improve or not?
And who improves?
And who improves, right? And can we then do that? So to go back to your point at the beginning, in the BeneMin study that you looked at, people tended to have modest inflammation. Well, that probably dooms the study to have a small effect size if it has one at all.
Right, so, and it looked at worsening of something that wasn't there, like negative symptoms, rather than treating negative symptoms. And preventive measures may be very different than interventive measures.
Yeah. And once you have negative symptoms and you're agreeing to be in a trial of schizophrenia, you're probably as negative as you're going to be. Right? So looking at worsening is probably not a good decision when you're designing your study.
One thing that
Michael, just to your point about inflammation and prediction. You know, as a, you know, maybe as a sort of a metaphor, think about diabetes type 2 versus pre-diabetes. So pre-diabetes, the individual exhibits impaired glucose, insulin homeostasis, has not met a threshold, which is really arrived at by statistics of what is in fact diabetes. And if one was to consider the potential utility of insulin, or for that matter, an insulin sensitizer, there's good reasons to believe that pre-diabetes would be as responsive, if not more responsive, than someone who has frank diabetes to some of these interventions. In fact, once you have later stage diabetes, where the biomarker is high at glucose, it turns out insulin supplementation becomes less helpful to these people. So I think along with markers, the selective marker, we have this kind of almost working assumption that that we need to see high levels of these markers. Really, in fact, to capture the subgroup most responsive. Maybe that's actually misguided. In fact, I think it is. And I think perhaps, again, it goes back significantly elevated. And again, diabetes, those with extremely high glucose levels because of frank total insulin sensitivity, don't respond as well to insulin. You wouldn't conclude insulin doesn't work in these people or doesn't work in diabetes. You'd say perhaps that mechanistic you know, opportunity, that window was closed for a variety of other reasons. So I think along with, you know conceptually think about which marker, which domain, I think we're still caught up in this, the bigger the amount, the more that's the population we want.
I was going to ask Christoph to address that, actually. Dan, we'll get to you afterwards, but
Yeah.
given your experience in the RAISE trial and others about that specific question.
Well, I mean, I wanted to respond by the fact that maybe diabetes and prediabetes is not the best model because people who are deranged in their insulin sensitivity have really a risk that this continues with age, with further weight gain, which happens over time. But the BeneMin study showed that the people, even on placebo, did not worsen their negative symptoms. So not all patients are on the trajectory of worsening something you want to prevent. That goes back to what Andy had said in the beginning, that you really need to be sure when you want to prevent something that it will happen in a large number of patients. And we're, I think, hard-pressed in psychiatry to necessarily identify these patients where progression is seen. And maybe here, again, deranging the system, challenging the system. Like if you do sleep deprivation and you see that people get some hypomanic symptoms, then you know, oh, well, maybe that's a higher risk group for future development of bipolar disorder. We need some probes. Just the baseline itself might not be good enough. That's why all tolerance tests actually, and identifying, or hemoglobin A1C, identifying prediabetes is better than just looking at fasting glucose. And we seem to be looking at fasting glucose a lot and not at things that are related to underlying precursors of mental illness worsening.
Dan, you were going to make a comment?
No, I was going to say that I think with the new wave of digital tools to look at the digital dust, that you can look at mood lability with ecological momentary assessments, which may be much more subtle than just you have a symptom or not. That also may help us look at who is vulnerable to having future events. And I think, the future is now, and that's going to happen very quickly, that we'll be doing studies by evaluating people with these real-time tools.
Absolutely.
And just to follow up on that, I think that you, Andy, are somewhat at the forefront of this attempt in psychiatry, that we may be able to use some of the existing commonly used screening tests, including hemoglobin A1C, including C-reactive protein, including other things that internal medicine doctors routinely ask in a majority of their patients, and then start with those types of information in large electronic databases to narrow the populations that we might be able to follow in a more prospective way, but with self-report and other tools that would allow relatively inexpensive surveillance of large populations.
Yeah.
Christoph, do you want to have a final couple comments before we close out the Hangout?
Well, I mean, I think thank you very much for coming together and using our little commentary as a gateway into a much larger discussion, which I think went from trial design, patient population selection, applicability of biological markers to clinical care, parsing biomarkers, target engagement, and also what can we learn from both medical disorders, but also from population data. And I think it was extremely rich, and hopefully what we've learned, and maybe the viewers have also listened to, can inform future data that will ultimately help clinicians to do the right test, identify the right subgroup, and then use a treatment that targets exactly that biological mechanism in that subgroup that leads to either better or worse outcomes.
I think that's a terrific summary, Christoph. I appreciate your taking the time from across the ocean to join us, and I hope you get back here soon. I wanted to thank everybody for joining us. All of our Hangouts are archived currently on YouTube. I wanted to express the thanks of our editor-in-chief, Andrea Cipriani, who could not be here with us today, but to also thank our guests, Christoph Correll. Christoph, thank you so much for doing this.
Thank you. Thank you, Andy. Thank you, Dan. Thank you, Michael, and also Roger. It was really a pleasure hanging out with you.
Right, really terrific. I'm Michael Ostacher. Thank you for joining us. Take care.
Thank you. Bye-bye.
Thank you, everybody.